Okay, thanks a lot, Val. Appreciate that. Okay, everyone, we're going to talk about pediatric and adult immunizations. So what's the purpose of immunity? The purpose of immunity is to recognize self from non-self, to recognize and eliminate infectious agents such as viruses and bacteria, and also to prevent infection in the future. Now, we do have some other videos that are on the LMS if you want to delve into the world of immunity a little bit more. But these, for the purpose of this update, these are the general purposes of the immunity. So let's get to know a few of the vaccines that are constantly being updated. First of all, just to review, live versus dead vaccines. So live vaccines induce immunity by actively replicating within the host. Vaccine strains are weakened so that the infection is either not apparent or very mild. We call this attenuated. And basically what they do is they mimic natural infection, which leads to the T and B cell activation. They're contraindicated in patients that are have immunodeficiencies, and certainly should only be provided either together at the same time or at least 4 weeks apart. Now, as far as dead vaccines or inactivated vaccines, these are used, they activate an innate response at their site of injection. They need to be injected well into a vascularized muscle. So they are an IM injection, whereas live vaccines are typically subcutaneous. Of course, there's a few variations where they're either provided orally. Dead vaccines most always require multiple doses in order to what we call booster doses. And so it helps to initiate that full, robust antibody response. Okay. Some of you may know this very old text, the Canadian Immunization Guide. It has been updated to 2018, and you can be found on the Government of Canada's website. This is a very handy website, and certainly I encourage you to check it out and to use it on a daily basis whenever you're providing immunizations. So we're going to just review a few of the newer immunizations that have been updated. First of all is the rotavirus vaccine, which is an example of the live live vaccine that's provided orally. Previously, it was a different vaccine. Now it's called Rotatech. And Rotatech is provided in 3 doses, scheduled at the 2-month visit, the 4-month visit, and at 6 months of age visit. The doses must be at least 4 weeks apart, and we don't initiate it in an infant that's over 15 weeks of age. The completion of the entire series must be before 8 months of age. Now, the efficacy of this immunization is about 85 to 98%. And this one covers for 5 different valents. This presents, of course, against rotavirus, which is a fecal to oral route, and certainly doesn't necessarily cause deaths, but increases hospitalizations in infants and children that are less than 8 months of age. Another example of a live vaccine, and one of the reasons why we have included this one was because of the outbreak of mumps in the Sioux zone in 2017. This is the measles, mumps, rubella vaccine, or MMR2 or Pryrix. With a full 2-dose regimen of this, the efficacy for measles prevention is about 100%. Measles, of course, is contracted through airborne contact. Mumps, it would be about 76 to 95% of efficacy. Mumps, of course, is spread through airborne contact or direct contact. Rubella has about 97% efficacy, and it's an airborne contact through contraction. Now, of course, there's always side effects, and so we do need to review these with our patients. And the side effects for the measles, mumps, rubella vaccine certainly can be pain around the site, redness around the injection site, low-grade fever, and even a rash. Occasionally, but rarely, a rash can occur even up to a week afterwards. It's a little more common with the varicella vaccine, but certainly can happen with the measles, mumps, rubella. Now, there also is a theoretical risk, because it is a live vaccine, that the patients could develop measles, mumps, rubella as a result of the immunization. Although not very common, it is more of a theoretical risk. The routine intervals for the MMR, the first dose is provided at the first birthday, or 12 months of age, followed by a second dose, which is usually provided as a combo, MMRV, between the ages of 4 to 6 years of age. Now, often people ask why we don't provide the MMRV twice, and that's because MMRV provided earlier than for that 12-month of age increases the risks of seizures, particularly febrile seizures. So it's important that we do provide the measles, mumps, rubella separate, and then of course at the 15-month of age and well-child visit, they would receive the varicella separate. And then at 4 to 6 years of age, they would receive the combination of the MMRV. Influenza, of course, there's been many different types of influenza vaccines that have been developed. The most recent ones are flu-Laval, tetra, flu-zone, quadrivalent, the flu mist, which is provided intranasally and is a live vaccine. And these have been provided either as quadrivalent or trivalent. More recently, the flu-Laval tetra, which is a quadrivalent, has been provided to both children and adults. And then there's a flu zone, which is a high dose, which is provided to the elderly over 65 years of age. The influenza vaccine protects against influenza A virus as well as influenza B. And influenza, of course, is passed on through airborne contact. There's about a 30% efficacy, but of course this differs year to year depending on the strains that are flourishing within the communities. And it depends on what area you're in, which community, which area, whether you're in Canada or other places. Now, of course, laboratory efficacy rates are much higher because it's a bit more of a controlled setting, so it can actually get up to about 80% efficacy. Now, certainly we don't see that in the public rates, and that's just because, again, of the high rates of travel. Nonetheless, the routine for providing the influenza is an annual injection or nasal spray. The age to receive the immunization for influenza is at 6 months of age. If they're between the ages of 6 months and 9 years of age, they should receive 2 doses, and these are at least 4 weeks apart. And this is to initiate that antibody response. Once they've been provided the 2 doses, at least 4 weeks apart, then they would just receive 1 dose annually. Now, certainly if they're over the age of 9 years of age, they wouldn't require a second booster dose, and they would just receive the single dose. For more information on influenza and the changes and whatnot, they can be found at the Canadian Immunization Guide online, which I alluded to earlier. The herpes zoster virus, or otherwise known as shingles, there's a live vaccine called Shingrix. Now, certainly you may be familiar with Zostavax, which has also been very familiar over the last few years. This has recently been publicly funded for the ages of 65 to 70 years of age. Otherwise, there is some evidence that patients can receive it at 50 years of age, but they would have to pay for it separately. Within the communities, again, this is publicly funded between 65 and 70 years of age. Herpes zoster, of course, is either through direct contact, or it can be really airborne contact. The efficacy for protection is about 51%. And mainly, it's about almost 70% preventative with efficacy for post-herpetic neuralgia. And of course, we know herpes zoster is contracted earlier if you have been exposed to chickenpox, which then lies dormant within the basal ganglia. And then later on in life can come out and cause very familiar shingles type rash, which affects usually surrounding dermatomes. So usually you have a one-sided rash that's unilateral and also goes through the different phases of having a burning feeling and then moving to the vesicular and then crusting and then hopefully not being left with the post-herpetic neuralgia, which is a neuropathic pain that can be endured as a result. So certainly we want to make sure we provide education, as we know that we can prevent, hopefully, these long-term effects of suffering from shingles. Now, of course, the side effects for receiving this vaccine would be pain, swelling at the area, redness around the injection site. And again, because it is a live vaccine, there is that theoretical risk that it could initiate a response. But again, that's mainly theoretical. Moving on is the human papilloma virus, and the vaccine that's been developed for this is Gardasil 9. Now, certainly we've seen move through Cervarix and Gardasil 3, and then 4, and then I believe 6, and then now 9. So as this develops, it covers more and more strains of the human papilloma virus, which we know there are many. Human papilloma virus is passed on through direct contact, and with a 3-dose series, we can have up to 99% protection. Quadrivalent and 9-valent preparations are available, as I mentioned. The routine doses are usually for males and females, 9 years of age to 14 years of age, and it's a 2-dose cycle for them. So they would receive 1 dose at day 0, and then another dose 6 months later. Now, certainly, it can be also provided to males and females over the age of 15, but these are in a 3-dose interval, and that's day 0, 2 months later, and then 6 months later. Again, this was previously or originally provided only to females, but we do know certain people, for example, Michael Douglas, who had throat cancer as a result of human papillomavirus. We certainly know that this affects males as well as females, and so now this is covered for both boys and girls. Okay, so those are a few of the updates for immunizations. Let's now move on to immunization procedures. Certainly, it's important to review your medical directives. These are available on the LMS under the module for immunizations for adults and pediatrics. Medical directive, of course, is given in advance by a physician, ordering authorities to enable an implementer to decide to perform the ordered procedures under specific conditions without a direct assessment by the physician or the authorizer at the time. And so certainly, please make sure that you do review these, as we are responsible to abide by the medical directives. This is an example of the Ontario publicly funded immunization schedule. It's important that we do follow these, as this is what is alluded to in the medical directives following the provincial or the following the immunization schedules that are outlined by each province. This, of course, is the December 2016 schedule, and you can see some of the immunizations that we did talk about just recently. For example, the Shingrix, you can see at the bottom there. Moving along the horizontal axis, you'll see the ages. Moving along the vertical axis, you can see the different immunizations. So PDSL, Prevnar 13, Rotarix, or now Rototec, Men-C, MMR, and so on. Moving across, and when you see the diamonds or the rectangles or the other shapes, you can use the legend below to determine them. I'm fairly sure that you have had some experience with this, so I won't go much further into it. But if you did have any questions about the immunization schedules, certainly there is a useful tool on the Canadian Immunization Guide website, which is a separate one which you can look up immunization schedules for any patient in any province. If you would be interested to learn more about this, feel free to contact Val or myself, and we can help you with that. So as I mentioned, taking a closer look across the vertical axis, you can see 2 months, 4 months, and 6 months. And then we can also see along the horizontal, or the vertical axis, rather. So there's the immunizations that are provided. So interruptions within a vaccine series shouldn't be completed for any reason. Certainly, if a patient has identified and we have documentation they've received immunizations, then we would not need to repeat them. Now, the question lies when a patient said they've received them, but we don't have documentation. There is a possibility that they may not, in fact, be immunized for it. So there's a couple of ways that this can be done. One is through revaccinating and providing a second dose. Certainly, there are, of course, the adverse effects that which we would review with patients anyway. But otherwise, another way would be to check titers for certain types of antibody responses. For example, measles, mumps, and rubella. Now in the north, most likely, and sometimes the most easiest way to go about this is to provide that immunization again. Now, as I mentioned, if it is documented this has been provided, if the person has not followed up with what is the routine schedule for their immunizations, then certainly we would not have to repeat it. Now, the last slide, or the slide that I showed you about the Ontario Immunization Guide, that was, of course, for the routine schedule. There are also different tables for ketchup, and that's not ketchup and mustard, that's for the ketchup 1 schedule, the ketchup 2 schedule, and then the ketchup 3 schedule, which are for different age groups. And certainly if you have a patient that comes in at 4 years of age or 9 years of age and needs to be caught up on their immunizations, you would use those tables. Some of the barriers to immunization are important for us to review because it's important that, it's important that we're prepared to answer the questions from the patients that they may have regarding immunizations. And so some of these barriers that we may want to address are a result of either what people have read on the internet, and some of these might be as a result of their own cultural beliefs and or practices. Certainly, we don't want to provide any barriers for immunization, and they should be responsive to the patient's needs or family's needs. When feasible, as a community health nurse, we should certainly try to schedule appointments in conjunction with appointments that the patient already has, and ensure that immunizations are both the patients and parents can be informed of the immunizations that either the children or themselves would need to receive, and that information can be accessed. A good resource is immunize.ca, which also has an app that people can download for their phone to learn more information about the immunizations that are available. One of the other reasons, as I mentioned, why people may have some barriers or may not feel that they are informed is because of what they've heard at other places. So you may recognize this young lady here that has Jenny McCarthy, who has, of course, mentioned that and supported the fact that the anti-vaccine movement. So the question lies in most people wondering about whether vaccines are safe. In fact, they are. They've at least 10 years of research to be approved by Health Canada. Vaccines are used in Canada and they are safe and effective. And then finally, they are readily monitored. Okay, and they are monitored by Public Health Agency of Canada and also Impact. So will vaccines make you sick? So in fact, they will not make you sick or give you the disease per se, with the exception to live vaccines and that theoretical risk. But again, that risk is so low, the chances of them actually contracting it without the immunization are much greater risk. So most vaccines do not contain a live vaccine, and those that do have been severely weakened enough to initiate the immune response. So the question and the answer to this question is no. Now, certainly side effects can make people feel unwell, and it's important that we do let them know that they may feel some malaise, they may feel some achiness, and that they may have some of the adverse effects that are associated with each vaccine. The last thing that people are usually concerned about is what's found in vaccines. So certainly vaccines are either dead or weakened viruses or bacteria. Adjuvants, which are used, can help to help the body's immune system to create a better response. And some of the adjuvants that have been used are things like aluminum salts, but they're naturally present in our environment and have been proven to be safe for over 70 years. Additives is another one, such as gelatin, and preservatives they help to maintain the quality and effectiveness of vaccines so that they can be stored for a much longer period of time. Gelatin is used in some vaccines to protect against against freeze drying or heat. As well, they are used in live vaccines as a stabilizer, and it is a low risk for reactions. Some of the other things that you may find in vaccines are residuals, and they are used in the production process, but then are removed in the final product. An example of this is formaldehyde. And formaldehyde is used to inactivate some viruses and toxins. It naturally occurs, formaldehyde actually naturally occurs in the human body to assist with metabolism. There's approximately 10 times formaldehyde in a baby's body at any point in time than there is in the actual vaccine. So it's important that people do get the information that's correct. Certainly, as I mentioned, immunize.ca has a wealth of information and much more than I've provided in this update. Again, I encourage you to visit that website and also encourage patients to visit as well. Consent and documentation is important that we review this so that everyone is on the same page. So of course, we obtain informed consent for the administration of all immunizations if it's someone who's of age or their parent or guardian. They must be informed of the disease related to the vaccine, the component within the vaccine, the immune process, which we talked about earlier, and also information about the immunization schedule and what to anticipate if there's any other booster shots. This is a picture of what the immunization documentation and consent form looks like. And it's important that we complete this for every vaccine that's provided, including the influenza. Let's break it down a little bit closer. I'm sure that you're probably familiar with this, but it's important that we do review it. The first part on the first page provides some screening questions, and there's 10 screening questions that it's important you review. The answers were either yes or no, and certainly any of the questions that provide an answer that may contradict the immunization, it may be best to wait until the patient is feeling better. But in fact, most vaccines, the only reason to not vaccinate is usually if the patient is quite unwell, has a significant fever, or has recently had another vaccine that contraindicates. For example, a live vaccine within the 4-week period. At the bottom of this same page, we have, at the bottom of this page, we have the client's consent for information. It's nice with some tick boxes here to make sure you review each of the informed consent processes. We can record all of the different vaccines that are provided, and then also we can either state whether it's written or verbal. Now, of course, this would be written if it's signed by the patient or the parent or the guardian. The date is provided, and then there's also mandatory nursing actions, which is also in a tick box form that we can make sure that we have all available. For example, anaphylaxis kit, the client's immunization history reviewed, teaching the risks and benefits of vaccination, teaching the signs and symptoms of the reaction, and that could be the anticipated signs and symptoms and the not anticipated signs and symptoms. So the things to expect and the things to not expect. For example, anaphylaxis would be something that we would hope to not expect, but we have to make sure we inform because it is a potential risk. Something that a patient may expect is redness or irritation around the injection site. There's an area for nursing notes, and then finally we're going to make sure you print your name, provide your signature, and as well as your initials. Now the reverse side of this form is going to be faxed to public health, and you can see that the number is at the bottom here. This is where we record all of the information, and at the top certainly is some demographic information, which I don't have as a picture in this slide. I've focused in on the vaccine portion of it. This is where we provide the trade name for the vaccine, the lot and expiry, the route, the site, whether it was related to high-risk criteria. We're going to provide our initials and the dose amount and time. If you only provide 2 vaccines, you can cross off or strike off the boxes that are not used. Print your name, sign, and initial, and then ensure that this form is faxed down to public health. Also, please make sure that this form finds its way into the patient's chart, which is typically on the right-hand side under and always on the top. So whatever the most recent vaccine is, the nurse will be able to locate, or a physician or nurse practitioner. If by chance there's an immunization error, either one that you make or one that you identify, it's imperative that it's identified and addressed. Errors must be documented on a med error form and reported to the nurse in charge and to the NPC. Errors may also be found on documentation forms that are sent in for data entry. This must be reported to the immunizing nurse for clarification, and if warranted, the NIC or the NPC should certainly be informed. The system is not meant to be punitive, it's rather a way to learn to hopefully prevent these occurrences from happening in the future. Tuberculin skin tests are certainly a test that are regularly done in the North. Recipients, either patients or clients, they may have had a contact with active tuberculosis. Routine screening is done between the ages of 4 and 14-year-olds in the Thunder Bay zone and the Moose Factory zone. Routine screening is also done at 4 years of age with no BCG history in the Lac Seul, Pikangikum, Poplar Hill, Sandy Lake, and Mishkogokemang areas, First Nations. When required, prior to being provided the BCG vaccine as well. That would be another time that the TST would be provided. The BCG vaccine, which I just mentioned, it's important that we identify that this is not currently being provided. It's certainly being reviewed at this point in time, and agency RNs are not certified to administer this vaccine. The tuberculin skin test, or MAN2 test, is a tool for screening and is not an immunization. And basically what it helps to do is to help with the diagnosis. The TST, as I mentioned, is typically given either if you're suspecting that there may be tuberculosis exposure, or if the patients are between 4 to 6 years of age before they go to school. It is typically done as a 2-step, meaning that the first TB test is provided, and then it's interpreted within 48 to 72 hours. And then a second test would be done 1 week later. That is what the 2-step test approach is. At each time, 48 to 72 hours later, the induration is measured only, not necessarily the redness or any inflammation. We're looking at elevation or the induration, which can be measured. So what happens if the workup is positive? So it's important that if the reaction site is between 0 and 4 millimeters, in general, this is considered negative, and no treatment is indicated. But if a child is less than 5 years of age and high risk of TB infection, then we would want to consider. If the measurement is 5 to 9 millimeters, we want to consider this positive when the patient may have an HIV infection, either contact with infectious TB within the past 2 years, fibronodular disease on chest x-ray, organ transplantation, TNF alpha inhibitors that they may have been on, or the other immunosuppressive suppressive drugs such as corticosteroids, as well as end-stage renal disease. Now, certainly, if the induration is greater than 10 millimeters, we would consider this positive if the TST conversion has been within 2 years, if there's diabetes, history of diabetes, malnutrition, silicosis, or if there's hemorrhagic or hematologic malignancies. You can see an example of the ruler that's here to measure the induration. You can notice in the picture that there's some erythema, but the elevation or the induration is being measured and not necessarily the erythemic ridge. Now, certainly there is a medical directive for the tuberculin skin test as well as documentation form, and it's important that you familiarize yourself with both. All of these forms are available on the LMS and can be found in the module for immunizations for adults and peds. This particular form, I think, is self-explanatory, very similar to the immunization form in the fact that it has demographic information, some of the tuberculin screening questions, consent, and, of course, signature and date. This is the backside where either the two-step process can be documented, and then the fax number to public health where these can be faxed to. Reporting adverse events. Certainly we want to make sure that these are reported and that perhaps this may be a lot number relation, or it may be something that has been fluke. And so it's important that we do make sure that we identify these so that patients can be, one, managed, but also can be addressed at a much grander level. So management of adverse events. The vaccines are safe and continue to be a positive contribution to overall population health. However, there is a slight risk of adverse reactions as a result of vaccination. It's important we review this with patients and their family members. Local reactions are the most common occurrence, and certainly some of those I've mentioned in this presentation already. They normally present as indurations, pain, sensitivity, redness, heat around the injection site. These are generally self-limiting and they don't require treatment. The adverse events following immunization, or AEFI form, is used to complete if there is an adverse event. Now, an adverse event is any untoward medical occurrence in a vaccine which follows immunization, which does not necessarily have a causal relationship with the administration of a vaccine. So we want to make sure that any adverse event may be any unfavorable and/or unintended sign, abnormal laboratory finding, or symptom or disease. So it's important that even if we do not seem to think that it might necessarily be related to the immunization, but an immunization was provided, it still constitutes an adverse event, and the form should be completed. This is an example of the form, and I've identified some of the major areas with the large text boxes. Certainly, if you want to explore these forms much broader, they can be found on the LMS. At the top of the first page is patient demographic information, followed by some of the specific adverse event following immunization information. Then, if there's any immunization errors, they can be documented on this as well. The impact, as far as any signs or symptoms as a result of the adverse event, your information as the reporter, and then on the second page is if there's a local reaction, if there's more of an allergic or an allergic-like event, neurological events, or other, such as GI or other situations which may be related to the immunization. Once these are completed, then they should be faxed down to public health. Any adverse event following immunization, the nurse in charge should be informed so that they are aware of this form being filled out as well. Especially as agency nurses, we want to make sure that these types of adverse events are communicated so that when we do leave the community, if there's any follow-up, that nobody's blindsided and they are able to contact you for further information if need be. So the procedure for reporting an AEFI, or an adverse event, the nurse who identifies it notifies the zone communicable disease nurse by phone immediately. Once the patient is stabilized, of course, that's the priority. We're going to fax the AEFI form within 24 hours. The nurse will inform the patient that the AEFI will be reported to the local public health unit and Health Canada so that they can be contacted with recommendations for future immunization. The CDs, the zone communicable disease nurse forwards copies of the medical to the medical officer, the zone medical officer, and to the local public health unit, and then the regional communicable disease coordinator. There's lots of people involved here. As a copy of this AFI form is with the recommendations for future immunization is then sent to the zone CD nurse within 2 weeks, who will contact the nurse as a result. The nurse will review recommendations with the patient, and then the patient will be immunized or not immunized as whatever is indicated. Okay, so moving on, we're going to talk about needle stick injuries. And certainly, we want to make sure that prevention is key. So in order to prevent needle stick injuries, we should certainly use routine practices, such as using correct personal protective equipment and avoiding recapping needles. We should certainly make sure that we're drawing blood work or starting IVs in a safe area where we won't be bumped or interrupted, and certainly make sure that we have all of our materials all put together ahead of time so that we are not rushing and reaching around trying to obtain different things that we might need. So if by chance a needle stick injury does occur, then certainly we want to report that to the nurse in charge. We want to allow that wound to bleed freely and wash it with copious amounts of soap and water. We're going to complete the unusual occurrence form and forward it to the zone nursing office within 24 hours. This form can be found either through contacting your nurse in charge, or it can also be found on the LMS. Review the client's blood serum status for hepatitis B antigen, the anti-hepatitis B, hepatitis C, and HIV. If the blood status is not known, then we have to obtain consent from the client to obtain the above serology. Certainly, you should be tested for the anti-hepatitis B surface antigen, as well as the hepatitis C, as well as hepatitis C and HIV as soon as possible. Physician or nurse practitioner can be consulted immediately to receive post-exposure prophylaxis. And certainly this can be as a result of, depending on the severity of the needle stick injury as well. Those blood tests can certainly be done at repeat times, repeat intervals, usually immediately, at 1 month, at 3 months, 6 months, and sometimes even 2 years later. Or sorry, 12 months later. Okay, let's talk about the cold chain procedure. Not too many slides here, but just to review a few things that are very important for you to remember. Vaccines must be stored in a dedicated vaccine fridge. This vaccine fridge shouldn't be used for any food or any types of other things other than the vaccines. Vaccines must be stored in the middle shelves, away from the walls or any cold air vents. They do not leave any vaccines on site if refrigerator will not be monitored for an extended period of time. And we don't put vaccines into the door as well. So we want to make sure that they're in the center, most possible area of that vaccine fridge. Pardon me, and to also make sure that there's a functional thermometer, which we typically check with our routine in the morning and evening. This is an example of a vaccine layout where you can see the, of course, log temperature book. Open the door only when necessary. Keep that vaccine fridge between 2 and 8 degrees Celsius. As I mentioned, don't store vaccines on the door shelves. Stock only a 1 month supply. Store full bottles of water on empty shelves and also in the door. This helps to keep and maintain the temperature. Now, never leave vaccines outside of the refrigerator. So if you are going to be obtaining vaccines for a patient's visit, just grab what you need and bring those only single vaccines. Don't bring the entire box out. Stock vaccines on the first first in line as a first used basis. So of course, those that are going to expire later can be behind those that are going to expire sooner. And finally, store only vaccines in the refrigerator. Your lunch does not go in there, or your yogurt or whatever. Finally, emergency procedures. For emergency procedures, it's imperative that we review and identify the anaphylaxis. Anaphylaxis is, of course, an acute hypersensitivity reaction with multi-organ system involvement that can rapidly progress to a severe life-threatening reaction. Anaphylaxis can occur after immunization, although it is very rare. It generally begins within the first few minutes after the injection, and it's usually evident within the first 30 minutes. And certainly there are different levels or gradings that anaphylaxis can take hold, from grade 1 being a generalized urticaria to a level 4 of hypotension, collapse, and loss of consciousness. All of these would be managed with this treatment protocol. So this, the basic management for post-immunization anaphylaxis non-hospital setting protocol is available in all communities. The document is available on the LMS, and I encourage you to have a copy either on one of your mobile devices or have a physical copy on yourself when you travel to the north. The first role is to promptly administer an aqueous epinephrine 1 to 1,000 by IM to the mid-anterolateral aspect of the thigh. We want to record the time and the dose that's provided. We repeat this every 5 to 15 minutes as needed to a max of 3 doses. Don't use the same site as the immunization, as this can not be as effective of a dose of the epinephrine. Then we want to activate the emergency response system if it hasn't been done already. Certainly, this may be also calling for help and asking for assistance. Position the client on their back or in a position of comfort. Elevate their lower extremities. Place on side if vomiting or unconscious. If they're pregnant, they can be placed in a semi-recumbent position on their left side with their legs elevated. Certainly, if they're unconscious and not breathing and they don't have a heart rate, we would initiate CPR. But we're going to monitor their airway, skin, heart rate, blood pressure frequently for changes in condition. Establish an oral airway if necessary. And then, of course, being the fact that we are in a position where we may not be able to manage them, we may have to arrange for transportation, requiring consultation over the phone with the physician. And then of course, we would go into that protocol as far as medevacing a patient if necessary. There's a few documents that are helpful for determining the dose, and this is a table for the dose of epinephrine. The use of an auto-injector if they are 15 to 30 kilograms. Give a junior dose if they are less than 30 kilograms. Give them a standard dose. Or sorry, if they are 15 to 30 grams, we're going to give the junior dose. If they are greater than 30 kilograms, we're going to give the standard dose. And certainly, it says do not use under 15 kilograms, and you can see the doses here. The vials, of course, are available in the north in the medication carts, and can be located in that area. There should also be available in each of the rooms an anaphylaxis kit, which has the aqueous epinephrine available as well. Table 2 has a dosing chart for Benadryl, and it's also based on weight. And I encourage you to review that also. So the role of community health nurse, as far as this goes, we want to make sure that all supplies are stocked in the anaphylaxis kits. So that includes that we make sure that we are checking this with our routine checks for the rooms that we're working in. The checklist for this can be found on the LMS. We want to maintain the anaphylaxis kits and ensure that supplies are sufficient and that the expiry dates haven't surpassed their time. We want to make sure that we ensure that the reference material is also current and up to date, and that information can also be found on the LMS. Finally, this is the last slide for immunizations. If you require any assistance, the support line is fantastic, and certainly call it and have some of your questions addressed. Also, you can visit the website for the Canadian Immunization Guide, which can also assist you to determine the plan of action for your patient and families. Excellent. So let's move on to our next section, and that's public health, communicable diseases, sexually transmitted infections, and contact tracing. The chain of transmission, of course, is pictured here. This involves the infectious agent, reservoirs, portal of exit, modes of transmission, portals of entry, and suspected host. If any of these are compromised, then of course we run into issues, and there are strategies as to what could be used within each one of these different chains of transmission. Communicable disease control management system, basically the confirmation of a diagnosis. We would review the lab slip, review and confirm the case of definition if it's reportable. We have, I don't know whether I have a picture in this slide deck, but there is a list of communicable diseases and those that are required to be reportable. As far as case management goes, we want to investigate the history of the disease and provide counseling. We are going to provide treatment for the disease and any symptom management, immunization or immunoglobulin as needed, contact tracing, and we'll talk a little bit more about that further. Prevention activities such as community education, targeted education, harm reduction, and community immunization blitzes. Outbreak management, which is covered in subsequent presentations and a little bit later in the presentation. And finally, surveillance and reporting. And so that's important that when we are reporting these diseases, that we ensure that it's faxed and that the NIC is aware. So as far as control of the environment, we want to make sure that our equipment is clean, that there are sharps containers available, PPE, hand hygiene, safety, and engineered medical devices. Administrative controls, of course, are policies, procedures, staff education, such as this, personal protective equipment like gloves, gowns, masks, eye protection, and ensure that your N95 fit test is done. And finally, additional precautions are signage, client isolation, and dedicated equipment. It's important that we review where these personal protective equipment and isolation equipment is, especially working in the north, because we may not necessarily have a specific cart that is designated to this, which we may see in other hospital settings. There is a reportable disease form, which you can see, First Nation and Inuit Health, Ontario region reportable disease form. This, the new term, diseases of public health significance, is now used. For example, hepatitis and tuberculosis are reported on a separate form, submitted by fax to a communicable disease nurse. And then finally, any management of those clients with the reportable diseases, we always consult either the MD or NP and ensure early involvement of the zone communicable disease nurse and public health unit. And these forms help to initiate that response and also make it a systematic response so that nothing is missed. These forms can be found on the LMS. I encourage you to review them so that you're familiar with them. This is, of course, the list of reportable diseases, as I mentioned earlier, and it certainly has, if you come across any of these diagnoses or any labs that come back that confirm them, we want to make sure that this is reported. Viral hepatitis is an example of one of the communicable diseases. For example, hepatitis C. It's often tested for when starting Suboxone or during initial prenatal visits or well-man or well-woman examinations. Ensure the date of any symptoms if the patient had symptoms. It helps the epidemiologist determine if there's any newly acquired or older infections. The management typically is symptomatic, and that's management with Tylenol, 325, 1 to 2 tabs every 4 hours, PRN. Also, we want to make sure that we're using some caution given the fact of liver involvement and that Tylenol is metabolized in the liver. So that's the reason why it's a lower dose, but we certainly also want to make sure that we continue to monitor these patients closely. Gravel can also be used, if need be, for symptomatic management. Follow your clinical practice guidelines for further management for hepatitis C. There's a couple of resources, but one in particular is the HIV, AIDS, and hepatitis C document through Health Canada. You probably find this in the north in hard copy, but can also be found on the LMS. And it goes into much more depth as far as hepatitis C management and HIV management within the communities, and it certainly goes much more in depth than what we can provide in this this update. So I'd encourage you to be aware that it's available, but also to become familiar with it as well. A couple other reportable things would be invasive group strep A, which has kind of made a big impact in the north as of recently. So some of the causes for strep infections are, of course, group A streptococcus. The risks include underlying disease processes such as diabetes, chronic heart or lung disease, kidney problems, and cancer. And some of the significant symptoms are usually fever, and then of course severe pain, almost pain that doesn't seem to be justified. It seems to be out of the unusual to the actual site of the lesion. Gas, otherwise known as or invasive gas infections, are a severe and often life-threatening infection. And it's usually spread within the blood and can reach the cerebral spinal fluid, deep muscle, or even fat tissue within and even into the lungs. It can manifest in multiple ways, including through pneumonia, bacteremia, and association with a simple cutaneous infection. And so it's important that we do keep our eyes and our ears aware of this, given the increased prevalence in the isolated communities. Two of the most severe causes for invasive group strep are necrotizing fasciitis and streptococcal toxic shock syndrome. These infections can be fatal and certainly require medevac and attention immediately. Risk increases with underlying diseases, as I mentioned, and it's the early signs of symptoms, of course, are that fever and severe pain. So it's important that we do this. But certainly people that are more compromised are going to show signs of dizziness, confusion, abdominal pain, and so on. So we want to make sure that we are alert to this and respond immediately. There is an invasive group strep document. Just key information here, it is 8 pages long. As I mentioned, there has been an upsurge in invasive group strep and infections, and so the initial can present as I mentioned, a very simple cut, impetigo, scarlet fever, and then becomes invasive when there is cardiac, renal, or neurological symptoms that involve. A good example is a recent case of a group of several kids with increased blood pressure, hematuria, and edema, and all the kids had a recent history of strep throat. All developed acute post-strep glomerulonephritis and were medevaced and placed into the ICU. This was an intuitive nurse that identified the increased blood pressure, hematuria, and edema that was occurring in this community, and it was within 1 week, every child in that community was screened for any open sores, scabies, proteinuria, and their blood pressures were assessed. So it's important, as I mentioned, that we come together, and it's also important to recognize the impact that nursing can have in these communities. Streptococcal toxic shock syndrome certainly, as I mentioned, is one that's very significant. In order for it to be present, the following clinical signs are apparent within the first 48 hours, so occur very quickly. That includes hypotension and then 2 or more of the following: renal impairment, coagulopathy, liver involvement, or acute respiratory distress syndrome. All of these require immediate evacuation, immediate medevac and management. Some of the other differentials certainly you'd be thinking of are cellulitis, sepsis, or septic shock, which of course would also lead you down the path to medevac, stabilization and medevac. So the management for this would be initiating the medevac, ensuring that you have additional assistance, oxygen at 6 liters, and then PRN to keep those saturations between above 97. Starting 2 IVs with normal saline to keep them open and bolus as needed. Refer to medevac and consult the physician to start antibiotics, and use your clinical practice guidelines to continue to manage these patients. Rabies exposure is something that can be experienced in the north as well. Rabies, of course, is transmitted through saliva from a rabid animal that penetrates the skin. This can then move further to affect the central nervous system and cause further complications. Some of those symptoms, and the initial symptoms, would be headache, fever, malaise, poor appetite, itching, tingling around the bite site. Certainly later on, around 2 to 10 days, you can experience with hyperexcitability, anxiety, hypersalivation, muscle spasms, delirium, and convulsions. And so it's important that if there is exposure, that these public health is contacted, as it is reportable, but also to make sure that we contact public health to ensure that the proper vaccines can be provided to assist with management. Some of your differentials may be delirium, tremens, drug reaction, acute psychosis, tetanus, or meningitis. It's important that we complete and submit the rabies reporting form to communicable disease nurse and environmental health officer as soon as possible, as I mentioned. This is an example of the form. It can be found on the LMS. If the animal is domestic, the banned environment health officer will follow up with the owner to ensure that quarantine of the animal is done for 10 days. The animal is not killed, and so this is one thing that has changed over the years to have more humane ways of managing suspected rabies exposures. Mainly, when the animal is killed, we're unable to conduct the post-mortem assessments for rabies. But the disease can be prevented through the use of rabies immunoglobulin and rabies vaccine in exposed individuals prior to the virus spreading to the CNS. So that's why it's important to initiate the response and have this form filled out so that the patient can receive these immunoglobulin as well as the vaccines. Make sure to include the patient's weight on the post-exposure to calculate post-exposure prophylaxis, as it is based on their weight and dose. So much like any of the open wounds, we want to make sure that it's flushed and that they're well with soap and water and rinsed, that we consult the MD or NP immediately, and then the forms are, of course, filled out. The CD nurse or medical officer will determine if rabies vaccine and immunoglobulin should be given and advise on any other measures that should be taken. Of course, with any injury to the skin or breaking the skin, we want to consider tetanus toxoid IM on the first day of treatment as well. This is the pharmacological intervention, so using the Imovax, which is a vaccine that's provided on 0, 3, 7, 14, and 28 days, and then as well as the immunoglobulin, which is provided around the bites and into the area that has been traumatized, as well as into the muscle. If anatomically feasible, a full dose of rabies immunoglobulin should be infiltrated into the area around the exposed wounds. Any remaining volume should be injected into the IM site. Multiple wounds, all sites should be infiltrated if possible, and the public health unit or CDC nurse will collaborate with the community health nurse to get treatment to the community as soon as possible. It's not normally stocked in the community, so that's the reason why we want to make sure this is provided. The client should not have live vaccines within 4 months of being given the rabies immunoglobulin, which is important to document and to have on their chart so it's visible. The tuberculosis is another disease that can certainly is more prevalent in First Nation communities, and we must be aware of. The causes, of course, is Mycobacterium tuberculosis, and the symptoms are usually a chronic cough greater than 3 weeks, hemoptysis, fever, night sweats, fatigue, and weight loss. This is spread through droplet and can multiply into the alveoli. There are latent and active effects of this, and so the latent, the immune system builds up a wall around the infection, whereas in an active infection, the immune system is unable to suppress, and this is when it's transmissible. 10% of latent infections will develop into active, and so it's important that we do recognize these symptoms and manage and monitor these patients appropriately. So a latent infection, or an LTBI, primary infection, but the patient does not have the active disease and cannot transmit the organism to others. The risk of active disease is high in certain groups of people with latent infection. With active disease, the person has active disease and is contagious when they have high numbers of tuberculi or tuberculous bacilli with the involvement of the respiratory tract. And so this is why it's very pertinent if other family members have been exposed that they are also assessed. So there's many differential diagnoses, including chronic or subacute pneumonia, COPD, bronchiectasis, lymphoma, and other malignancies, fungal infections, which also should be considered and assessed for. The tuberculin skin test, as I mentioned earlier, is something that can be provided and assessed and utilized to identify if anybody has been exposed to it before. Certainly, I didn't mention earlier that if anybody has excessive burns or eczema or other skin conditions, you would want to avoid those areas and look for an area that is not affected. All right, so sexually transmitted and blood-borne infections, as well as a contact tracing, is what I'll review in the next few slides. The treatment, there's a medical directive for sexually transmitted and blood-borne infections. This, of course, is found on the LMS, and I'd encourage you to review it, but we'll cover a few of the things here. First-line treatment for chlamydia is still azithromycin 1 gram PO for a single dose. If this is of course provided if the patient is over the age of 9. If they're under, then we're going to consult. Gonorrhea, of course, is ceftriaxone 250 milligrams IM times 1 dose, as well as azithromycin 1 gram PO for 1 single dose, given the fact that chlamydia can often coexist with gonorrhea. For any second lines, we're going to be consulting the MD or NP, and we can certainly reference the Canadian sexually transmitted infections guidelines put out by Health Canada. Some of the non-pharmacological managements for patients with suspected sexually transmitted or blood-borne infections would be advise them of appropriate administration of medications. In some cases, that's actually monitoring them take the medication, and of course administering it if it's the IM injection. This would of course be documented in the plan section. Counsel the client about abstinence during the course of treatment. So this would be at least for 1 week after the being provided the antibiotics to avoid sexual intercourse. Document the patient's contacts for contact tracing, and we'll show a few forms, or I'll have a couple slides a little later to review those forms. We want to teach the clients about barrier methods and for protection of intercourse. And of course, condoms are available in the community health center, so to be able to provide those as well to patients should they choose to want them. Remind the client that they would need to require a test for cure, particularly in higher risk groups, which may be a result of being lost for follow-up. And so it's important that we do ask them to follow up for the repeat test of cure within the 4 to 6 week period. Blood testing for these areas, there's just a couple slips we have here. This is the HIV serology test in Ontario. It can be nominal or anonymous. Anonymous testing at 50 sites are done in the province. Now, certainly keep in mind the fax machine, and when these come in, that this information does not become available given other than the people that are involved in their circle of care, meaning yourself and the nurse in charge. Prenatal women are offered HIV testing as initial prenatal workup, so it's important to make sure that we do offer that, especially given the fact that if there happened to be a positive mother for HIV, there is a possibility for transmission, and there are medications that can be provided to assist to ensure that the baby can be as healthy and protected as possible. We also want to offer HIV testing to anybody that is an IV drug user or any high-risk behaviors which may expose them to blood-to-blood contact. For more information on those high-risk exposures, you can find that in the top right part of the HIV serology test requisition. This is the public health form, which can be used for VDRL, or otherwise known as syphilis. Hepatitis B and C, as well as A, can also be done for this. There are many other public health requisitions or tests that can be done with this, but specific for this presentation, I'll review the VDRL, hepatitis B or C. Now, certainly if somebody is experiencing symptoms and have no previous exposure, then you would check for an acute infection. If you're suspecting that maybe they've had this for a while and you're more or less screening for a chronic infection, you would select chronic infection. Of course, if somebody's applying for a either rehabilitation, or they may be applying for a school or some other program, then we may check their immune status to see if they've been if they do have immunity to hepatitis A, B, or if they've been exposed to hepatitis A, B, or C. For contact tracing, we always assume the presenting client is the index patient until proven otherwise. Obtain a list of all sexual partners within the last 3 months or more, if needed, but ideally for the past 3 months when samples are going to be collected of those patients. If test results are positive, all contacts must be reported and tested appropriately. And we want to make sure that we determine the mode of transmission. So was this via airborne, sexually transmitted, IV drug, or blood-to-blood contact, etc. This is what the contact tracing form looks like. Of course, we've kind of highlighted a few of the major topic or heading areas. This can be found on the LMS to peruse at your leisure. Certainly 6 sexual health education questions are on the back related to relationship, sexual behavior and risk, sexually transmitted infections, history, reproductive health, substance use, and psychosocial history. The rest of the information is really related to a physical description of the patient, clinical information, and then which treatment was provided. Now, one of these would be completed for each patient, starting from the index patient. This is a list of the entire contact tracing and helps to identify all of the patient's demographic information, as well as any relationship, immunization status if needed, and whether or not they've been treated or referred on. These can usually be found in a specific document book and would be usually overseen by someone who's overseeing this program. But if you do have somebody that you identify as a positive, certainly connect with the NIC so that this can be tracked accordingly through the program coordinator, as well as yourself being involved with connecting with the patient. So I mentioned about follow-up. So we want to ensure that we do follow up with these patients, especially if there's been previous treatment failure, if there's any compliance issues or that's uncertain. If we have re-exposure to an untreated partner, if it's likely that that may be the case, or if certainly if the infection occurs during pregnancy, we want to make sure that follow-up is and test for cure is completed. Okay, so let's move on now to neonatal well baby and well child assessment, as well as we'll talk a little bit about pediatric nutrition. So of course, Canada's most recent census identified First Nation communities as the largest growing segment of our population. The Rourke baby record is typically used, and you're probably very familiar with this. This is an evidence-based tool to guide primary care providers in completing well infant and toddler as well as well child assessments. There's a great website. It's www.rourkebabyrecord.ca, otherwise known as RBR. This website has a lovely interactive site, which you can see a screenshot here, where there's blue sections where you can highlight over for further information. Now, this information comes directly from the education pages, which fall at the end of the Rourke baby record. You can see in the top right corner that this is a guide. This is guide 2. Certainly guide 1 or guide 3, guide 4, all occur for different age groups. This would be ages 2 months to 6 months. Along the horizontal, you can see the ages as well as some demographic information. Along the vertical, you can see the various different topics like parent giver or caregiver concerns, nutrition, education and advice and development, so on. We'll go a little more specifically here. You can see guide 1, guide 2, all the way to guide 5 are provided. Guide 5 is a table for charting immunizations, but it's important that FNIB charts immunizations separately, and it's not necessarily on the Rourke record. So please use the appropriate FNIB immunization charts, not the Rourke charts. The guidelines and resources are fantastic to be able to utilize to ensure that you have appropriate information, whether it's based on dental, about introducing foods, or any other information pertaining to growth or development. Following the Rourke baby record is the GRIG record, and the GRIG record follows patients beyond the 5-year mark. The Rourke baby record starts from pretty much the first week of life until 5 years, whereas GRIG takes it on from 6 until 18 years of age. This again is a clinical tool. It's evidence-based, and similar to the Rourke baby record, functions very similarly. Across the horizontal, you'll find ages. Across the vertical, you'll find various different health topics, including weight, height, BMI, psychosocial history, developmental or nutrition, education, etc. This GRIG guide helps you at each interval, just as the Rourke baby record does. Now, it's important, FNIB requires the community health nurse to record on these records, but also in the narrative. So we would still require to log a narrative interaction with the patient, and certainly you can mention within it, please see Rourke baby record or the GRIG health record. Moving back to the Rourke baby record is the main 7 areas and how often they are checked. So height and weight and head circumference is pretty much every visit. Head circumference is pretty much for the first 2 years of life. The eye assessment is done at every visit, mainly assessing for strabismus is especially pertinent during the first year of life. The developmental assessment, nutritional, and parenting is done at every visit. Now, the previously called NIPISing, now known as Look-See checklist, or the NIPISing developmental screening guide, is now the new branding for this resource. You can see that there are different ages that these are provided for, 4 months, 6 months, 9 months, and so on. And what this does is it provides the parent or guardian with some outlined milestones that the patient should be meeting for either growth or development. And it's helpful that you can provide these prior to your assessment, for your well child or well baby assessment, so that when the patient or the caregiver and the care provider can sit down, complete this, so when they come in, then you can review it with them and answer any questions they may have. These may be available either through tear-off usually in the public health office, but certainly you may want to ask where these are available in the community that you're working. If not, we do have these saved in the LMS, so you can save them as a PDF yourself and then print them if you need it as you're working in the north. The Look-See Guide is designed to provide an easy-to-use method of recording the development and progress of infants and children. The Look-See Guide provides a general overview or snapshot of the child's development on the day of that screening. Now, most children will have mastered the skills by each appropriate age. It's important to note that if one or more no answers are marked, then a referral is required to an MD or an NP. Previously, this was 2 or more. So now it is, if there's 1 or more, a referral is required and should be documented as part of your plan in your SOAP note. Each one of these look-sees explores 13 developmental stages, including vision, hearing, speech, language, communication, gross and fine motor, cognitive, social and emotional, and finally self-help. This is an example of the 6-month form. Part of the forms do provide some unique engaging activities that the parents can do. So you can notice on the left-hand side here is the check marks, and on the right side is some of the information as to how parents and guardians can engage with the patient. So you could certainly rip off half of this and provide it to the parent or guardian, and then the other half can go into the patient's chart. So for newborn assessment, there's a video of a full comprehensive newborn assessment. Myself and my son, when he was a baby, he's now 2.5. So certainly if you wanted to touch base on a newborn assessment, then certainly that is available to you on the LMS. To just define terms, infant is a newborn to 12 months, toddler would be greater than 12 months to 4 years of age, and finally a child is 4 to 10 years of age. When we, as I mentioned, the video is available on the LMS, we won't show it to you now, but if you feel that that's part of your learning objectives, then certainly please feel free to check that. One of the things we wanted to include in this update, as we recognize that certainly many of these topics would be review for you, but hopefully we're stimulating your some of the questions that you might have, or answering some of the questions that may have been going through your mind. One of them is regarding the use of WHO charts, the World Health Organization charts. These charts are used, and they should be used at every well child visit, and the patient's height, weight, and head circumference should be plotted according to their age. The key point is that healthy infants do follow their own curve, and healthy infants are also proportionate. For example, if you have a child that's at their 3-month visit and they're measuring in the 75th percentile, but at the 9-month visit they drop to the 50th percentile, you're kind of wondering what's going on there. You'll want to expand a little bit more on your history taking as a result of seeing if there's been any changes in intake or output, as far as what foods are being provided, or formula or breastfeeding is being done, how often and how much. The red flag component of this is, of course, if there's a crossing of 2 growth curves. Okay, so you can see each curve is predictable. So if a kid typically lands around the 15th or 7th percent growth curve, they should follow along that, and they may slowly creep up. Sometimes they may creep a little bit lower, but certainly they shouldn't cross 2 curves. that's a red flag. That requires consultation and definitely further investigation through your history. It may be a matter of error from the person that's actually plotted that's on the chart. So keep that in mind too. In certain cases, it may be plausible or it may be pertinent that you have this patient come back within a week to ensure that they are in fact gaining weight and growing appropriately. But nonetheless, if there is identified red flag, there should be a consultation document in your plan. We wanted to make sure that we reviewed the gold standard that a rectal temperature is used for any child that's less than 2 years of age. Really, a gold standard is a rectal temperature on any age. And having a 2-year-old myself, I know certainly well that my 2-year-old as his well self would not tolerate a rectal temperature. So in that case, if you have a child that's generally well, but you're concerned about them being febrile, you could certainly, if they're stable, you could certainly check them under their armpit or any other means. Keeping in mind you want to use your clinical judgment. Now for any child that you are concerned about, again, that rectal temperature would be the gold standard. And usually the fact is that if the 2-year-old's allowing you to do that, they're pretty significantly sick. Now, keeping in mind if the child is on chemotherapy or has other contraindications as a result for rectal temperatures, then you would forego that and use another means. When to start foods, and let's provide a little bit of information. This comes from the Best Start documents, which are provided and available online through the LMS, as well as if you search Best Start in Google, you can certainly find it. Most of these starting foods guides are certainly guidelines, but are based on research as well. So when do we provide and start solids? So we should always recommend and try to encourage breastfeeding throughout, especially in the first 3 months of life, and particularly longer and beyond, even 2 years is recommended through the World Health Organization. Now, certainly that's not for every mother, and we shouldn't shame mothers for choosing not to breastfeed, but certainly there are benefits to breastfeeding, which I believe I have a slide in here about that. But we want to make sure that we do offer support for breastfeeding when needed. Now, when to include and when to start patients on solids. So when they can hold their head steadily, when they can sit and lean forward, when they can open their mouth and when food is offered, and when they can kind of state when they're full, either by turning their head or pushing the spoon away. They can usually pick up food and show some interest in being expanding beyond formula or breast milk. We can introduce solid foods as early as 4 months of age, but again, they must meet these other criteria. Ideally, solids should not be introduced any later than 6 months of age. So we can begin with savory foods and then move to sweet. This tends to be the way things have been done in the past, although it doesn't necessarily have to be done that way. Along with breast milk, offer solids. Iron-rich is really where we want to get the best bang for our buck. So looking at either iron fortified or certainly pureed or lumpy ground meats and things like that. Can be lumpy, doesn't necessarily have to be completely pureed, but keeping in mind to educate parents and guardians about the risk for choking. Minced traditional country meats can also be introduced at this time and certainly may be culturally appropriate, but also may also be high in iron-rich sources. Well-cooked meats and meat alternatives such as beef, turkey, moose, deer, pork, everything, even whole eggs, they can all be provided, no problems. There's not many restrictions as far as what to offer. Even as far as what we do offer and that approach, usually the iron-fortified cereals such as rice, oat, barley, wheat, mixed cereals can be provided. Cow's milk and milk products can be introduced around 1 year of age, mainly because of the digestive enzymes and the patient's ability to tolerate that and gas production, etc. We want to, of course, monitor for those choking hazardous foods like cut hot dogs, grapes, even marshmallows, which can be lodged into the esophagus and very difficult to clear. So introducing allergenic foods, we want to include common allergy-causing foods by 12 months of age, such as well-cooked eggs, smooth peanut butter paste. These foods include, it could be cow's milk or eggs, peanuts, tree nuts, soy, wheat, fish, and other seafood. Now, when I mentioned about introducing these, it used to be that we would have to wait until, or we would be suggested to wait until about 12 months of age. The recent evidence actually suggests that we should be introducing these earlier, around 6 months of age. And so the idea is that we provide small amounts as a trial over a 3 to 4 day period, small amount, middle of the mouth, middle of the day, middle of the week, mainly because that's when the emergency rooms are not as busy. But certainly working in the north, the community health centers there, and we should introduce these, slowly increasing the amount. So a small amount of peanut butter and then increasing that on the weekly basis. Continue to give these foods at least twice weekly as part of a varied diet. So you do want to have a plethora of proteins, carbohydrates, and make sure that it's a variety of different sources of food. Again, keeping in mind that you want to have the iron-rich foods as keeping them as a priority. Some safety reminders, we do have the clinical practice guidelines that you can review for further, but talking about smoke alarms, carbon monoxide detectors, making sure medications and cleaning supplies are locked up or put up in an area where kids are not going to get to them. If there's any firearms, that they're locked up. If there is access to, if there's water or water heaters that are available in some communities, you want to make sure that they are temperature controlled. Cribs are imperative to use. One, to make sure they're safe. Drop cribs are illegal, and they should not be used for risk of asphyxiation and choking, as well as injury to children. Co-sleeping should be strongly discouraged as a result of risk for asphyxiation. Although this can be difficult in certain communities where bed sharing is highly prevalent, again, keeping in a special area that's specific for the infant or child is imperative, and ensuring that there's no risk for falls. Car seats should be promoted, and they are the law off reserve. Although you will notice that kids are often carried in lap or not put into car seats, but they should be promoted for the sake of safety. Ticonogans, we do want to remind patients there is some evidence to suggest that there can be some risk of hip dysplasia, although there is some evidence that the belief is that ticonogan can help with leg development as well. But we do certainly want to make sure that, of course, when we're doing our infant examination, if a patient does come in a ticonogan, we are not the one to remove the child from the ticonogan. This is something that the parent or guardian, we would ask and their permission, and they can remove the patient and undress them. Certainly asking their permission first is culturally relevant. It's also a sensitive, culturally sensitive, and ensures that you are cognizant of the circumstances of a ticonogan, in that some of these have been used for multiple generations. The one nice thing about ticonogan is that once the laces or the wraps have been loosened, while the infant is resting, you can get a good idea of their heart rate and respiratory rate at rest before they get undressed and more alert and perhaps maybe even crying. Of course, as we mentioned, we'll probably mention this a few more times, our duty to report. So certainly the Child and Family Services Act is important that we address if there's any child that appears to be suffering from abuse or neglect, and there's reasonable grounds Now, this is applied to any child that is less than actually 18 years of age, so not 16 anymore as of last year. It's been increased. So if there's any child that appears to be suffering from abuse or neglect, then we have a duty to report to the Child and Family Services. So some of the community resources, as I mentioned, the Child and Family Services, it could be either Tikanagan if you're in the Sioux Lookout area, or Peritano if you're in the James Bay area. Community health representatives are a fantastic resource. Some of the band-run children's services like Healthy Babies, Healthy Child, it's important to connect with those services, maternal child health programs if they're available, and counseling services. There are many more, but these are just some of the few ones. Okay, so let's move on to the assessment of a sick child, acute, urgent, and emergent presentations. Again, this is not going to be extensive. We just want to make sure to cover on a few important things. For example, rheumatic fever. So rheumatic fever is an inflammatory disease of the connective tissues, which involves the heart, joints, skin, nervous system, and subcutaneous tissues. It arises from the immune complications of a beta hemolytic streptococcal infection. Generally can be from pharyngitis or cellulitis 2 to 5 weeks prior to the onset. The symptoms are usually pretty significant fever, joint pain, redness, swelling, shortness of breath, edema, cough, fatigue, and they can even have a rash at either at a delayed time. For non-pharm intervention, basically, if you're thinking that this patient has rheumatic fever, you're going to consider a medevac and get that activated soon. For pharmacological management, we are going to involve antibiotics, which would protect against strep infection, and as well as medications shouldn't be started until the diagnosis is clearly established. So we're going to be consulting immediately with regards to these patients. And if an IV is being started, we're going to be drawing blood cultures. So one of the ways to diagnose rheumatic fever, and one of the best ways that I can hopefully elicit into your minds to remember, is the Jones criteria. So the Jones criteria basically follows this acronym, and there are 2 major or 1 major and 2 minor with evidence of a recent strep infection. So some of those major areas are polyarrhythmias, or polyarthritis. So this is inflammation of the joints, carditis, subcutaneous or sub-Q nodules, erythema bargentum, or Sydenham chorea. The minor ones would be arthralgia, prolonged PR interval, fever, or elevated ESR-CRP, which we may not know until a little later, once the blood work results come back. So let's review these each together. So the J stands for joint. It's the earliest symptomatic manifestation for acute rheumatic fever, and it usually presents within 21 days of a group invasive strep infection. Most common and most severe in teenagers and young adults, but may be severe enough to even limit their movement. And in some cases, for younger kids, they may not even be able to share that they are experiencing the pain. So irritability may be the case. It affects several joints in a quick succession, and you can go from one area to another. We call this migration. And certainly radiographic evaluation is not routinely performed, mainly because of the migratory effect of the joint involvement. The O is regarding the myocarditis. Now, certainly it's because the heart is kind of in the shape of an O there, or pericarditis, and it can occur with acute rheumatic fever. The predominant manifestation is a carditis that presents with a valvulitis, especially in the mitral or aortic valves. And this can be established. You can identify this through auscultation findings, and of course echocardiogram, which you may not have, which may show some mitral or aortic regurgitation. So damage to the cardiac valves may be progressive, chronic, or resulting in cardiac decomposition. So you want to make sure you listen to these patients for any additional murmurs, clicks, rubs, or and irregularities. Rheumatic fever, or the N of Jones, is the nodules or subcutaneous nodules. These are usually painless, pea-sized. Oftentimes patients may not even recognize them until they're pointed out. They're common along the exterior surface of the bone and knees, lasts usually only a few days, and resolves without incident. They must have a history of a strep infection, and you can see a couple pictures here of where the common areas that they can occur. E is the erythema marginetum. This is a pink, faintly red, non-purpuric rash involving the trunk. Sometimes the limbs can also be involved. It usually occurs early again, very similar to the joints in acute rheumatic fever. In some instances, it persists and can reoccur on and off throughout their experience with rheumatic fever. The erythema marginetum is most commonly occurs in patients with acute carditis, but has been reported in patients with chronic carditis as well. It rarely occurs as a sole manifestation. The outer edge of the lesion is sharp. The inner edge is diffuse, so you can see the picture here to the left. The lesion is also known as erythema annular, since the margins are usually make a ring-type shape. The individual lesions may appear and disappear and reappear in a matter of hours, and a hot bath or a shower can make them more evident. And finally, this is Sydenham chorea, and this is also known as the St. Vitus stance. This is a neurological disorder consisting of an abrupt, non-rhythmic, involuntary movements, muscular weakness, and emotional disturbances. Typically presents about 1 to 8 weeks or 8 months after the group A strep infection, and can occur as an isolated finding. More commonly, it occurs in girls, and often can result in them refusing to go to school and cause social isolation due to shame and embarrassment. They usually fully recover within about 6 weeks, but sometimes it can go as long as 6 months. And on rare occurrences, it can be much longer than that. The movements are more marked on one side versus the other, and usually resolves as they sleep. There are some great examples of videos of this on YouTube if you're interested to check this out. I personally have not seen this in clinical practice. I have seen rheumatic fever, but I have not seen this component of rheumatic fever. Okay, so we're going to now move on to mental and behavioral health, emergency sexual assault, and child abuse and neglect. And so let's move on here. So behavioral health, of course, is the balance between the mental, emotional, physical, and spiritual health. The disparities between Aboriginal behavioral health and that of the rest of Canadians is a concern. Very much like other disease processes and inflictions on other Canadians, the First Nations are affected about 3 to 4 times that of the general Canadian population. Now, certainly, this is ensured to be a review, but a certain approach to history and assessment of behavioral health we'll review over the next couple slides. So our assessment should elicit a few things. Certainly, we want to provide specific information about behaviors, thoughts, feelings, and as they relate to any backgrounds, their personal experiences, and then any circumstances or contextual issues that are going on. It may be a recent suicide in the community, it may be a recent divorce, it may be a recent change or move. The BATHE acronym can be used as a way to approach in providing empathetic care to patients, and the acronym goes as follows. First of all, getting a background. So what's happening in your life? The affect. How do you feel about the situation? Trouble. So what worries you most about the situation? About handling. What resources do you have, and how are you handling with this? And then finally, empathy. Your response is reasonable. And let's talk a little bit more about this. So showing empathy and ensuring that we take this effect is more likely and has shown that people are more likely to engage in a therapeutic relationship. Further, to obtain history, we want to gain a general description, chief concern, any difficulties or changes, increased feelings, any somatic changes, maybe palpitations, headaches, other somatic changes, any integrative patterns, and personal perceptions of what's going on. What do you feel is the issue? What do you feel is causing some of these symptoms that you're experiencing? And then finally, any other relevant history. The mental status examination, or the MSE, we have a great document that's on the LMS that really goes into this in depth. And I encourage you to take a look at it, especially for your documentation, to provide a nice in-depth history as far as an MSE examination goes. But the main heading areas are documenting a person's appearance, their behavior, their speech, their mood or affect, their thought processes. Are they logical and coherent? What is their thought content? Is it logical? Is their perception, is it appropriate? Is their cognition appropriate to their level of education? And also, what is their insight and judgment? Is it impaired or is it appropriate? Finally, we want to make, once we've identified that history, we make a provisional diagnosis, determine the need of emergency. And some of the things that would require immediate reaction and consultation is if the patient was homicidal or had violent impulses. That may include maintaining safety for yourself. Excuse me. Is a patient a potential for suicide? Have they divulged any information to yourself that they have interest in killing themselves or have thought about either self-harm or dying? If they had an inability to function independently, perhaps maybe they have psychosis and require to be stabilized and medevaced out of the community for further management and investigation. I mentioned acute psychotic symptoms as well as delirium, and we'll talk a little bit about that later in the presentation. So certainly we want to make sure that treatment goals should be identified and driven by the clients as much as possible, involving clients and in some cases families. Some of the people that we may involve in the circle of care are the physician, the nurse practitioner, clinical nurse specialist, depending on the community, psychiatrists, counselors, social workers, behavioral health or wellness workers, CHRs. Hospitalization, we may actually need to look at previous hospitalizations. The decision is only made in consultation with some of the specialists for the community, such as a physician or nurse practitioner. Some of the common problems that certainly I'm not going to go into in depth. There are some great resources on the LMS, as well as some videos that we have connections to. The clinical practice guidelines, of course, go very in depth into management for some of these areas too. That includes anxiety disorders, mood disorders, psychotic disorders, family violence, substance misuse, and cognitive impairment. Let's talk about anxiety disorders very briefly here. So anxiety disorders, and of course using the DSM-5 is the most recent book that helps to identify diagnoses for behavioral mental health disorders. And it should be important that we identify that a disorder is when certainly we all experience maybe anxiety or depression or some of these symptoms that we may describe, but a disorder is when the person's ability to function has now been affected. And that sometimes can be subjective, but it may be the person's own subjective reaction, and what they're saying to you is that they're now unable to function as a result of some of these symptoms. So for example, anxiety disorders could include generalized anxiety disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, social anxiety disorder, other specific phobias. It's important to know too, also, not even between these different disorders, there's often overlap. So, for example, depressive disorders and anxiety disorders certainly can not occur on their own. They may be present and overlap with each other. So symptoms that persist in greater intensity than expected and impair the daily functioning is what I alluded to earlier. Now, the GAD-7 questionnaire can be used and is based on the DSM criteria for diagnosis of generalized anxiety disorder. This is great, and I call it the mental health blood pressure for anxiety. You can have the patient fill this out, and if they're able to read and to write, otherwise you can walk them through it yourself. Certainly this involves a person to reflect on the last 2 weeks and to classify based on their symptoms, which are recorded along the vertical. So feeling anxious, feeling nervous, anxious, or on edge. Not at all would be 0 days of the 2 weeks. Several days would be 1 to 7 days. More than half the days would be 8 to 13 days. And if it was every day, it would be 14 days. Then the score can be calculated at the bottom, and you can determine whether it's a mild, moderate, or severe. Any moderate or severe should be consulted with the nurse practitioner or the physician for further management. And it also would indicate that this person would need to be have more regular follow-up, perhaps even weekly, maybe even more often, depending on some of the other risk factors that maybe you've identified. Some of the mood disorders that you may come across are major depressive disorder, seasonal affective disorder, postpartum depression, subsyndrome or minor depression, dysthalamic disorder, bipolar 1 or 2 can also be. Now, certainly it wouldn't be up to you to make these necessarily diagnoses, but it's certainly helpful to take a look through the clinical practice guidelines at each one of these so that when you're recording the symptoms and the signs of what your assessment has identified, you can certainly have an idea when you're consulting. And certainly it may be a consult to have a referral to a psychiatrist for diagnostic clarification and management. So for depressive symptoms, the blood pressure, as I call it, so the mental health blood pressure for this area would be the PHQ-9. Again, these documents are on the LMS and can be downloaded for your use in the north. These, again, very similar to the GAD-7, is a reflection over the last 2 weeks. The vertical are the different symptoms, for example, feeling little interest or pleasure in doing things, and then along the horizontal, either classifying it as a not at all, several days, more than half the days, or nearly every day. This can be calculated up and identified as a mild, moderate, or severe. And similar to, as I mentioned before, if they're moderate or severe, consultation should ensue and the patient should be followed up more closely. For further information on treatment, you can see the clinical practice guidelines. For the purpose of this update, we certainly won't go into depth on those treatment regimens. For psychotic disorders, they can present as delusions, hallucinations, disorganized speech, bizarre behavior, catatonia, withdrawal, or even social withdrawal. And as I mentioned, these prevalence rates within the First Nation communities are much higher than that of the general Canadian population. So for example, schizophrenia can occur as either positive or negative symptoms. These positive or negative symptoms could become and you can see the difference between the two. So positive ones tend to be hallucinations, delusions, thought disorder, disorganized behavior, or inappropriate affect. The negative symptoms can be slower thoughts, poverty of speech, lack of motivation, low energy, inability to gain pleasure, or a flat affect. Now, it may be difficult to actually elicit some of these symptoms from the patient if they're unable to articulate their own feelings and thoughts. And so this is where it's important if a family member or a friend is available and able to provide a bit of insight can be helpful. Now, certainly we do have to be careful within this area, providing consent, especially if the patient does have capacity. Of course, if they're, we want to protect privacy. And but it's certainly okay to obtain information from the person, from a family member, without giving information further about the actual patient themselves. So for example, you might interview the mother of the patient, of a 19-year-old patient, who's saying that this patient has been climbing up on the roof and threatening that they are some sort of Pablo Picasso or some famous person, and that they feel they can fly. So if that's the case, then that can certainly be documented that that was what the mother had stated. And then when you interview the patient, you identify that there's disorganized thought processes and there's some grandiosity and other symptoms. So certainly this is a case where a consultation would ensue, and further management would be identified between yourself and either the physician or nurse practitioner you're consulting with. Okay, family violence is important for us to just provide a bit of an update. Of course, it can be physical abuse, emotional or psychosocial abuse, neglect, financial abuse, or sexual assault. Val's talked to you a little bit about the sexual assault protocols, but it's important that we do keep this in mind. We know from the RNAO best practice guidelines that female victims report routine verbal screening for domestic violence as they are very favorable for it. So certainly asking it can be a question that can strike up emotions. We want to ensure that there's appropriate support systems involved, but we also may want to make sure that if there is abuse or family violence going on, that it can be addressed. And then, of course, remembering our duty to report. So we always want to screen when there's any history of physical findings of that indicate violence. If somebody is pregnant, if there's presentation after hours for multiple kind of vague type symptoms, such as chronic abdominal pain, chest pains, headaches, sexually transmitted infections. If they're dependent older adults, if there's an initial clinic visit and it's a new client, we want to make sure we screen, as well as for our well child, well adult visits, and then any preventative type care assessment, particularly for females less than 12 years of age. So history taking tips, some key things you want to remember, because if this does become, remember your documentation is always a legal document. So some tips we can offer you are state that the injuries, if they're a result of trauma, then stating them and documenting that they're a result of trauma. Also, when you're discussing with the patient, it's important to remember these things. If the abuser is present in the room, one, make sure your own safety is paramount, but as well as the safety for the individual. But we don't want to put the abuser down. So we keep very much to the facts and identify. We certainly want to make sure that state that the behavior is unacceptable. We don't want to reassure the client that everything's going to be all right, because in fact, we don't know that. We want to help the client to be as objective as possible. That's a strategy to use in de-escalating situations. We want to verbalize client priorities, encourage I messages rather than you messages. And then finally, we want to assess for any danger for children and, of course, remembering the duty to report. Substance misuse may also be an issue. It could involve stimulants, depressants, hallucinogens, cannabinoids. And we know that for Aboriginal patients, 26.3% reported substance misuse as a concern. Now, this was a study of in Ontario, and this was also in a northern community. So there are, and depending on which community you go to, just as there is in urban settings, an influence of substance misuse, but it's certainly we want to ensure that we do review this and that people are screening for the misuse of substances. One of the tools that we can use is the CAGE aid tool. So CAGE stands for, have you ever felt to cut down or change your pattern of drinking or drug use? The A stands for, have you ever been annoyed by others criticizing your drinking or drug use? G is, have you ever felt guilty about what ever happened when you've used drugs or drinking? And then finally, E would be, have you ever required an eye opener or something to overcome a hangover or withdrawal symptoms? Certainly, if anybody is positive to any one of these, then they would be at risk for substance misuse. Now, a tool that's actually quite useful is the alcohol, smoking, and substance involvement screening test. And this is otherwise known as the ASSIST tool. This is a great tool. It's a few pages long, but it helps you to elicit a very thorough assessment of substance use. For example, it talks about using which of the following substance have you ever used, followed by what have you used in the past 3 months, and then how often you've used them in the past 3 months, and then finally if any use of those substances have led to health, social, or legal or financial problems. The final pages help you to identify a plan and use some motivational interviewing to engage in the patient and determine where they are as far as their stage of change. If you're familiar with some of the smoking cessation programs or other programs, you'll be familiar with the 5 A's. So that's asking about use, advising them to quit, assisting or assessing their willingness to make that quit attempt, assisting them by arranging or providing counseling or pharmacological treatment, and then finally arranging follow-up. And then you continue this process of the 5 A's. One of the things you probably had experience with, or you may have experience with, depending on communities you're in, are harm reduction strategies. For example, one is the needle exchange program. This is an example of one of the charting forms that are used for the needle exchange program in the north of the Sioux Lookout region. Now you'll notice that the information provided is very general. It's a date, the gender, age, drug of choice, and whether or not, if it's a new client or a returning client. Then generally, if 10 needles are provided back, then 10 needles can be provided. And if there's other things that are required, such as snorting packages, condoms, or any disposable containers, they can also be dispensed as well. Now you'll notice there is a fax number at the bottom where these can be faxed to for ongoing harm reduction strategies and supply management. Some other harm reduction strategies would be the naloxone take-home kits, which has been something that's pressed against. It's been affected across Canada, and certainly Canada is not alone in this, but even the First Nation communities are affected by opiate use and abuse. And so naloxone kits, these take-home kits can be available. They can be either an injection by reconstitution or the nasal spray that can be available. There is a FNIB opiate overdose and naloxone policy. It can be found on the LMS in the mental health module, and I encourage you to review that. Basically, these naloxone kits are available to anybody that has an OHIP number, but they do require some training by pharmacy. Now, of course, as you know, in the north, we are the pharmacy. So if somebody is provided one of these or has any questions, just make sure that you have the adequate training involved to be able to review this with the patient. As I mentioned, these can be injectable or they can be a spray, but it's key to remember that these are not very difficult to review with the patient. So don't feel that you can't open up the instruction manual and walk the patient through the instructions that are provided there. There's an excellent video that's online. It's, I think, an Australian girl that portrays it, but basically it's she provides it to her teddy bear, and it's called naloxone. It's child's play. So really, it should be provided to education, and these kits should be provided to anybody that's at risk. All right, let's talk a little bit about behavioral health emergencies, including sexual assault and child abuse and neglect, just to review some of the major components. So one of the ones that is I find I get a lot of questions from, and Val and I have, is regarding the Clinical Institute Withdrawal Assessment for Alcohol Revised, so otherwise known as CIWA. So CIWA identifies the severity of alcohol withdrawal. It determines the appropriate care, and it monitors, assists in monitoring the client during detoxification. All right, this is to be completed on anybody you suspect of alcohol withdrawal. So These are patients that, who can talk and who have drank in the past 5 days. So if it's been over 5 days, then chances are they've kind of went over the hump of those of the major withdrawal symptoms. Now, keep in mind that if their capacity and their ability to recall may be implicated, you certainly, if you're in doubt, utilize the CWA. This is an example of what the CWA looks like. You can see the top areas where we can record vital signs and continue to monitor that. The middle part is where you can see the different types of withdrawal symptoms. They are recorded on a Likert scale from 0 being not experiencing any of the symptoms, for example, nausea and vomiting, to 7 experiencing quite extensive nausea and vomiting. And this can be this goes through nausea, vomiting, tremors, anxiety, agitation, paroxysmal sweats, orientation, tactile disturbances, auditory disturbances, visual disturbances, and finally headache. This can then be calculated into a number, and depending on that number, it depends on whether they're in a moderate withdrawal, severe withdrawal, or in a minimal withdrawal. Now, within that withdrawal protocol, your clinical practice guidelines will identify the medications that are used, usually Ativan or diazepam for management for those patients. If anybody is within the CWA tool is a moderate or severe, consultation is required, and continual monitoring is also required. Again, using this tool is important, but not to negate from your documentation of your narrative. So certainly you can address that this tool has been used in your narrative, but please ensure that you do also document that narrative aspect too. Delirium, just a quick review here. So delirium, we don't want to forget, again, it's something that is a sudden onset. It's a medical emergency characterized by an acute and/or fluctuation onset of confusion, and could be disorganized thinking or decline in level of consciousness. Whereas depression is more of a cluster of depressive symptoms. You could use the ICSI caps, which is you can use as a matter of looking at different symptoms. With regards to depressive symptoms, you could use your PHQ-9. These are generally over a 2-week period or slightly longer. Whereas dementia is more gradual and progressive, declines the mental processing and ability, affects the short-term memory, communication, language development, reasoning, and abstract thinking. These are generally gradual and can occur over months to years. One of the things to think of is I watch death. It's a bit morbid, but it's a good way to think about possible causes for delirium. And that includes infections, withdrawal from a substance, acute metabolic, toxins or drugs, CNS pathology, could be hypoxia, other deficiencies, endocrine, acute vascular trauma, or heavy metal toxicity. Now, each one of these, of course, have various different laboratory tests, vital signs, or certainly ongoing monitoring that would assist you to rule in or rule out these. But certainly, for example, a urinary tract infection may be the culprit, and once treated, those delirium symptoms would resolve. Aggressive behavior is certainly something that we want to be in tune to, given the area and the environment that we work in as far as nurses, whether urban or rural. We can often be in precarious and unpredictable situations. So it's important that we do engage in verbal and nonverbal techniques. If you haven't done de-escalation training, which I'm sure most nurses have, but it's an excellent opportunity to review how to approach situations where somebody may be aggressive and how to handle it so that the patient, one, can be safe and receive the health and care that they need for wellness. It's important to know that security must be around within the nursing stations. If it is not, let your nurse in charge know immediately. Certainly in communities, OPP or the Anishinaabe Aski Police or NAPS officers are available. So ensuring that you're in a safe area. If you feel unsafe at all, ensuring that security is available. Also, physical restraints like panels are available if needed, keeping in mind that there are protocols around that and documentation and ongoing monitoring. Pharmacological interventions certainly could also be used with consultation to chemically restrain somebody if need be. In extreme danger, lock yourself in the pharmacy. As you may know, there's often the front door lock, the lock to the clinic, and then there's a separate lock into the pharmacy. So that would be the safest place. Usually there's a phone in the pharmacy, which then you can call the police. The sexual assault and intimate partner abuse and a policy is available. Again, it is also located in the LMS for this module. I'd encourage you to take a look at it, but basically it involves us as community health nurses to provide unconditional and non-judgmental support, medical care, and forensic evidence collection to consenting individuals who have experienced sexual assault or intimate partner violence. So sexual assault risk factors can include physical or emotional abuse. Young females tend to be a higher risk. Attending evening events, students, First Nation individuals, individuals with disabilities, and individuals who've been previously assaulted, as well as children who have run away from home, all include risk factors for sexual assault. Again, your historical approach is going to use the BATHE technique as we talked about earlier. We want to screen for domestic violence. Also, as we talked about earlier, interview alone with the patient, ask non-leading, non-judgmental, open-ended questions, and ensure that it's those answers are documented. Ensure confidentiality, of course, informing that if there's any risks as far as harm to themselves, harm to somebody else or a child, that those are a duty to report. Family history of violence, and it would be also be an important thing to gain in the history. So the sexual assault evidence kits, as I believe Val did review these a bit, but we do want to ensure that we have permission from client. We want to they require quite extensive time to complete, so you would of course ensure that another nurse is involved, sometimes two nurses involved to complete. Ensure the instructions are followed, and that also for specimen collection, as well as for history and physical assessment. We want to make sure the patient is informed and that the chain of evidence is not broken. As I mentioned previously, child abuse and neglect can take the forms of physical, sexual, emotional neglect, Munchausen syndrome by proxy, or abusive head trauma, otherwise formerly known as shaken baby syndrome. Certainly you may know the period of purple crying, which is a strategy that was provided and is available online to review with parents, ways and strategies to prevent harm to children when they are, previously was called colic, but when they may just be during that time of period purple crying. So certainly we want to provide reporting. Caregivers should be made aware if we are going to be reporting to family services. Certainly sometimes this may cause a situation where they may be upset, but it's important that we do review with them that this is not necessarily meant to be punitive, but it's to ensure that there is adequate safety measures for the child. We want to obtain a written consent from the parent, guardian, or child if they're able to, and if they're of an age and the ability to provide that consent. Notify the Provincial Child and Welfare Services as soon as possible, provide with the provider's information, demographic information of the patient, contact information, history of the presenting child abuse, any witnesses, and any aspects that are contextual to the family's social history. The ATIP coordinator's office, this is a phone number here that you can contact. Otherwise, there's an email also if you have any questions. Again, these will be part of the slides which you'll have access to. So if you don't get a chance to write it down now, you can always access these later at a later time. Right, so we're going to move on to suicide prevention and assessment and treatment of the suicidal patient. And the role for the community health nurse is really teaching youth coping strategies, problem solving, life skills, and really developing that connection. As agency nurses, sometimes that's difficult, but as you probably noticed, you tend to go to the same communities and you may have developed some fantastic connections with community members, and particularly youth. We want to reduce access to lethal means, so certainly asking the questions, do you have access to anything that you could hurt yourself with? Perhaps a knife or a gun or anything like that. Ensuring adequate treatment for mental health services, so that's involving people in the circle of care and asking the patient for consent if they are interested in counseling services, either within the community or even outside of the community through NODIN or some other services that may be available. We want to address the determinants of health, understanding certainly that there are the indigenous determinants of health as well, that which Val talked about as far as how colonialism has affected families through intergenerational trauma. We want to ensure that family support is available, and if it is, to make sure that we utilize those to the fullest extent. Support youth groups or any other groups or programs that are available. And then finally, we want to increase awareness about mental health and treatment and management, as well as suicide and suicide prevention. Some of the risk factors and protective factors are as follows. Risk factors can involve social isolation, major disruption in life, mental illness, family history of suicide, substance abuse, peer teasing, poor school attendance, or previous attempts of suicide. Protective factors are, in some cases, the opposite. Good physical or mental health, strong problem-solving skills and communication, conflict resolution abilities, positive family and friends relationships, and positive attitudes towards school and life. Some of the warning signs are certainly a sudden change in behavior, increased use of alcohol or drugs or other substances, recent loss of a friend or a family member, many mood swings, outbursts, irritability or aggression, feelings of hopelessness, worthlessness, or despair, giving away valued possessions or putting affairs in order, purchasing items that could be used for suicide, having a plan for suicide, a preoccupation with death, talking about suicide directly, and threatening to die by suicide. It's important that if a patient talks about this, or if the patient doesn't even talk about it, that we ask the question, have you thought about killing yourself? Or have you ever harmed yourself or hurt your body in any sort of way? Opening up these questions and keeping them in an open-ended format allows these patients a platform to provide information. And whether they provide or share that information is entirely up to the client. And again, that's a matter of relationship building. It's offering that opportunity. So again, using the BAID technique for history, developing that therapeutic relationship, asking about suicidal ideation. Does the patient have a plan? What is the risk assessment? And the plan and the risk assessment, I'm gonna actually show you a short video that's excellent as far as using the Columbia Suicide Risk Scale. Any previous attempts? That's a very important question to ask. And again, you saw that as one of the risk factors. Asking their mood, maybe it's grading it on a Likert scale, on a 0 being low mood and 10 being the best mood you've ever experienced, or vice versa, just making sure that it's clear and documented. Any substance use, and maybe using the assist tool or Cage Aid to assist you with that. And asking the patient, do they want help? See where they're at. So When we're asking, we want to make sure we're clear. And I've been pretty clear in the way that I've been stating it, is asking the patient, have you ever wanted to die or kill yourself? It being this and stating it very bluntly like this doesn't dance around the idea of, have you ever thought about suicide, where there could be misinterpretations as far as terminology. So I'm going to show you a short video on the Columbia Suicide Severity Rating Scale. This is a scale that Noden typically has been used for quite a few years now, since moving away from their own severity scale. This is a feasible, low burden, short administration time scale that can be used. It assesses both behavioral and ideation, which is fantastic because sometimes there may be a fine line between the two, and this scale actually can help you to navigate that. It's comprehensive and measures that include only the most necessary suicidal characteristics. It's evidence-based, and it's been widely used around the world. So I'm going to share that video with you now.
Now this is the core of ideation for this scale. It's that 1 through 5 of increasing severity, again, starting with a wish to die. Have you wished you were dead, or wished you could go to sleep and not wake up? Or have you actually had any thoughts of killing yourself? No to those 2 screen questions, you move on to the behavior question. However, if it's yes to this second question, have you actually had any thoughts of killing yourself? Then you ask the next 3 questions, 3, 4, and 5. Have you been thinking about how you might do this? Have you had these thoughts and had some intention of acting on them? Or have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? You can't have methods, intent, or plan an intent if you don't have a thought of killing yourself. That's why 3, 4, and 5 are subcategories of 2. So this is what the screener looks like. If question 2 is yes, then you ask 3, 4, 5, and 6. If question 2 is no, you go immediately to question 6, which is the behavior question. Behavior. This is the definition of suicide attempt, which is a self-injurious act committed with at least some intent to die as a result of the act. First of all, it says self-injurious act. It doesn't say self-injury. There does not have to be any injury or harm, just the potential for it. So if a man puts a gun in his mouth and he pulls the trigger and luckily the gun failed to fire, even though he wasn't hurt, as soon as he pulled that trigger, that became a suicide attempt. And then it says, with at least some intent to die, with some being the key word. When people are feeling suicidal, they often have mixed motives. It just has to be that any part of them was doing this to end their life for us to call it a suicide attempt. So if 2% of them wanted to die and 98% wanted to make their girlfriend angry, that's what it gets called. And it used to be somebody would say, did you want to kill yourself? The answer would be no. You'd move on. Very often with that second question, the any part, did any part of you want to do this, you get a very different answer. And then it says, as a result of the act. That means the behavior and the intent must be connected. It must be the why, at least in part. Sometimes people cut because they're self-mutilating and they just want to feel better and they always have a background wish to die. Those 2 things do not equal a suicide attempt. It must be the why. And finally, we can infer intent clinically. One way we can do that is if someone denies intent to die, but they thought it could have killed them. Another way is what we call clinically impressive circumstances. That's a highly lethal act where no other intent but suicide can be inferred, like trying to shoot oneself in the head or jumping from an 8th story or taking 200 pills. No matter what they say, you can't infer anything but that. And what we're doing is trying to distinguish suicide attempts from non-suicidal self-injurious behavior. That's when they engage in the behavior purely 100% for reasons other than to end one's life. What we think of as self-mutilation to relieve internal pain, feel something, feel better, or what we call affecting external circumstances. That's getting something else to happen. That's the homeless person who wants food and shelter, or theoretically the man who goes up to the roof because he believes people will feel sorry for him if they think he's suicidal. He actually has no intention of ending his life. He just wants to get sympathy from others. Well, if that man accidentally fell to his death, that's just what we would call it, an accidental death, because there was no suicidal intent associated with it.
Okay, that's great. So that kind of gives you a bit of an overview of what's been going on as far as using the Columbia Suicide Severity Scale. Now we're just going to take it one step further and look at behavioral components and how this severity scale can be used for that.
Now, there's some other suicidal behaviors that are also important to assess. They just don't reach the threshold of an attempt. And the first one is called an interrupted attempt. That's when a person starts to take steps to end their life, but someone or something stops them. So he's on the ledge, poised to jump, and the policeman grabs him back. She has a gun in her hand. Somebody grabs it out of her hand. An aborted attempt is exactly the same thing, but they change their own mind. They stop themselves. He goes up to the roof. He turns around and changes his mind. She has a gun in her hand. She puts it down. He plans to drive his car off the road at high speed. On the way, he changes his mind and returns home. And the final category is what we call preparatory acts or behavior. This is any other behavior with suicidal intent: collecting or buying pills, purchasing a gun, writing a will or suicide note. So this is what the screener looks like again. And you see question 6 is actually it's all of those behaviors we just went through in one compilation question. Have you ever done anything, started to do anything, or prepared to do anything to end your life, with many of the examples that we just went through. So you know whether they've had an attempt, interrupted, aborted, or preparatory behavior in one question. Some more case examples. The patient experienced heartbreak over the loss of a guy. She took 4 clonazepam, called a girlfriend, and talked her, cried it out. She was dismissive of its seriousness, but indicated she wanted to die at the time she took the overdose. What would we call that? Attempt, interrupted, or aborted? Attempt. As soon as that pill was swallowed, the first pill was swallowed, it became an actual suicide attempt. During pill count, the study staff discovered that 6 tablets were missing. Upon questioning, the patient admitted she was saving them up so she could take them all together at a later time in order to kill herself. Interrupted, aborted, or preparatory? Preparatory, absolutely. This is the very example in the question, collecting pills. The patient reported he first started thinking about killing himself when he was 12. He thought about how easy it would be to pretend to fall in front of a bus before it was able to stop so that it would look like an accident. Although he thought about it often, he said he didn't have the courage to do it. Is that preparatory, ideation with a plan, or ideation with a method? Yes, that's ideation with a method. This isn't a plan yet. A plan would be, next Tuesday at 3 o'clock, I'm going to go into my husband's medicine cabinet when I know he's going to be away at the office so he can't come home to stop me. A plan is the what, where, when, and how worked out.
So it's nice to kind of have a few different case studies there as well. So just to kind of go through it. So basically it's 5 questions. And so you're going to ask the first 2 questions. And if it's yes to the first, and definitely to the second, as far as having, have you actually had thoughts of killing yourself, then you would go on and ask the associated thoughts, some methods, some intent, and plan of intent. If by chance they say no, they may be yes to the first, but not to the second, then you would move on to the behavioral component. So some management of a patient who may be actively suicidal. First is safety. So you're not going to leave this patient alone in a room by themselves with medications or potentially harmful things that they could potentially hurt themselves. So we want to make sure that we either keep this person supervised or move them into a room where they cannot harm themselves. We want to make sure that we assess the patient for any physical injuries and then treat. For example, if there's been any injections or if there's been any cuts or abrasions. Or if they were attempted to hang themselves, assessing them for risk because there could be a delayed response as far as swelling or injury. We want to choose the appropriate suicide risk tool. Again, talking about the Columbia Suicide Risk Scale, certainly appropriate. Contact the MD on call for medevac and call NODAN to send the patient out and arrange escort which is generally going to be the case for a patient actively suicidal. We can certainly create a safety plan if they do remain in the community. That can be documented in the plan section. Certainly creating a safety contract, those are not a legal binding document and really have no evidence for improved outcomes. So, but certainly documenting the safety plan and discussing that with the patient and or family members is paramount in ideal and best practice care. Certainly a Form 1, if the patient refuses admission, can be initiated by a physician through video conferencing or if the physician's on site. Now, a Form 1 can be initiated within 1 week of an assessment of the patient from the physician. So if the physician had assessed the patient within the week, Form 1 could be initiated. Creating safety plan, they are a proactive strategy, as I mentioned, typically to develop a collaboration between the clinician and anticipate any advanced crises. If you have any thoughts of hurting yourself, I will do the following activities to calm myself down, remind myself of the reason for living, and of course, those are around the person's thoughts and reasons for living. You would develop around that. Call a friend or family member. Their name and their phone number would be provided. Call a backup person. That name and number would be provided. Care provider, whether it's a nurse, physician, or doctor, psychiatrist, psychologist. Call a local crisis line, which I'll show you that at the end of this presentation. Go somewhere safe, or go to the emergency room. In this case, it would be the nursing station. If you feel that you can't get to the nursing station safely, then they will send somebody immediately. So in this case, it may be a family member contacting a family member or one of the CHRs or another member of the community. So for suicidal behavior, as I mentioned, non-pharmacological, we can establish that safety plan. We want to provide education, crisis intervention services, and initiate the family. For pharmacological management, certainly if there's an injury, we would treat any with antibiotics or any tetanus vaccinations. If poisoning is involved, then we're going to contact poison control. Otherwise, if there's underlying medical conditions, or if there's, for example, concurrent disorders where there's substance misuse, then certainly we would manage those in collaboration with other healthcare providers, including counselors and physicians or nurse practitioners. The medevac criteria for a patient who is actively suicidal would be somebody that is exhibiting destructive behaviors and is willing to attend counseling, exhibiting suicidal behaviors and is willing to attend counseling, a victim of a sexual assault or physical assault and is in imminent danger and remains in the community and is willing to attend counseling. And then finally, if there's any physical condition that warrants further medical attention or diagnostics. All right. And so that is it for me. I'm going to turn this over to Val. Thank you very much for your time.